Hi, my name is Dr. Paul Yong. I'm a gynecologist with a fellowship in endometriosis, pelvic pain, and advanced laparoscopy. I'm a gynecologist at the BC Women's Center for Pelvic Pain and Endometriosis in Vancouver, Canada, where I am also research director. I am an associate professor at the University of British Columbia, and I hold a Canada Research Chair in endometriosis and pelvic pain. Today, we're going to talk about the diagnosis and pain management of endometriosis. Yes, a key challenge remains for endometriosis, the long diagnostic delay, although a lot of work is being done to try to shorten that delay in diagnosis. In terms of the impact of endometriosis beyond pain and fertility, there's now lots of research showing it has an impact on mental health, that there are changes in the nervous system, and that there are social factors at play as well, including impacts on education and employment, potentially. So, a major challenge is the level of awareness of endometriosis, although I think that is improving in Canada currently. But when there's a lack of awareness, then it makes it more difficult to obtain a diagnosis. The second thing is that historically, surgery was required to make a diagnosis. And when that was the case, because of surgical waiting lists, that can also result in a delay of diagnosis. Another new issue is that imaging in endometriosis has really improved in the last decade or so, such that some subtypes of endometriosis, such as the ovarian endometriomas and deep endometriosis, can be diagnosed on ultrasound and MRI. However, the problem is getting that information out to care providers all throughout the country so that patients have access to expertise in endometriosis imaging right across the country in each province and territory. I'd say a major differential diagnosis for endometriosis is a diagnosis known as primary dysmenorrhea. So it's painful periods when other causes such as endometriosis have been excluded. There has been more research now on primary dysmenorrhea. There's likely hormonal factors involved, inflammation, also a role for uterine contractions. So some patients who present with painful periods may in fact have this condition called primary dysmenorrhea rather than endometriosis. In terms of other components of the differential diagnosis, a challenge here is that these other diagnoses can be present separately from endometriosis. So some could have, say, a diagnosis of painful bladder syndrome and not have endometriosis. However, it's also possible for a patient to have endometriosis plus these other diagnoses. So that I think is a major challenge we face here is that you can have more than one diagnosis contributing to chronic pelvic pain. So amongst these differential diagnoses would be from a gynecological point of view, would be adenomyosis of the uterus. From a bladder point of view, there's a condition called painful bladder syndrome, as a subtype of which is interstitial cystitis. In terms of the bowel, there's irritable bowel syndrome. And then there are also myofascial or musculoskeletal causes of pain in the pelvis, things like pelvic girdle pain, pelvic floor myalgia, abdominal wall, muscle-related pain as well. So again, these can be totally independent diagnoses on their own in someone without endometriosis, while on the other hand, someone with endometriosis could have one or more of these diagnoses simultaneously. I think one misconception about chronic pain and endometriosis may be held by some people is that it's something, the pain is something that patients have to live with because there aren't treatments available. And that's clearly not true. There are a range of treatments. So I think if there's that thought out there, that does need to be corrected. And otherwise, no, I think patients have it will raise difficulties for patients' access to care. Other misconceptions, I think, actually have to do around the fact that endometriosis causes three types of pain. nociceptive, neuropathic, and nociplastic. And so one cannot be just on the nociceptive side, which means, say, for example, endometriosis is only treated by surgery. I think surgery is very important, but for endometriosis, but the research shows that it cannot be the only treatment in some patients. Some patients, it may be, if their pain is purely nociceptive, surgery might be sufficient. That's it, and that's all needs to be done. But that's not the case for everyone. The idea that the pain is all patients, their pain is nociceptive, I think that is a misconception. And everybody's different. On the flip side, I think there's also a misconception. Some people feel that the pain endometriosis is only nociplastic. So there's no role for surgery. It's purely a chronic pain condition affecting the nervous system. And I think that's also a misconception because again, it depends on each particular case. In endometriosis, it usually starts with something that's nociceptive, the actual endometriosis lesions themselves. Also, again, it's possible to have nociplastic pain, which is this nervous system pain resulting in widespread pain and endometriosis concurrently. So you have to treat the endometriosis as well. And no doubt there are a small subset of patients with endometriosis or a history of endometriosis where the pain is mostly nociplastic and it should be treated appropriately for the best outcome. But again, I don't think one should be fully in sort of one philosophy or the other, saying it can only be treated one way or this way. I think the research is showing that endometriosis can cause pain in very different ways and in different ways in different patients. And so I think one needs to be flexible and holistic in how they're thinking about the disease so that all patients, regardless of how they're presenting, can be cared for properly.